So today we are going to study about the right lower lobectomy. So what is right lower lobectomy? Right lower lobe, the right lower lobe of the lung uh, resides in the lower posterior hemithorax. Lower posterior hemithorax, and its bronchovascular supply originates from the terminal aspect of the ILPA and BI next to the middle lobe structure. A right lower lobe resection can be a challenging procedure because, as in a middle lobectomy, the ILPA, that is pulmonary art, must be exposed through the central hilum at the confluence of the major and minor fissure. And if the fissures are fibrotic and obliterated, or if the ILPA is surrounded by lymph node, then access to the segmental vessels is difficult. So this is an important point for the right lower lobectomy. So as we can see here, this is the right lower lobe pulmonary artery. Right lower lobe pulmonary artery. So artery, we will color it as red. So it is artery. And right lower lobe bronchus. So this is right lower lobe bronchus and right lower lobe bronchus and inferior pulmonary vein. So this is inferior pulmonary vein. So this is inferior pulmonary vein. This is bronchus, right lower lobe bronchus, and this is right lower lobe pulmonary artery. So, and this is anterior view of the right lower lobe with the right lower lobe highlighted. So this is right lower lobe is highlighted, and the right lower lobe bronchus resides medial to the primary anterior arterial blood supply. So bronchus is medial to the arterial blood supply. And this is the posterior view of the right lung, right lower lobe highlighted, and the inferior pulmonary vein is the most inferior. So from posterior view, inferior pulmonary vein, right inferior pulmonary vein is the most inferior structure, hilar structure, and resides posterior to the arterial branches and bronchus. Inferior pulmonary vein, it is most inferior and posterior to the right lower lobe. This is right lower lobe bronchus, and this is right lower lobe inferior pulmonary vein, and this is artery. So if we see from posteriorly, then vein is the inferior most part. Vein is the most inferior, and bronchus, and then artery. So this is the central view of the right lung, and the middle lobe bronchus and superior segmental bronchus to the right lower lobe take off opposite each other. So this is middle lobe bronchus and right lower lobe. This is right lower lobe superior segmental branch and pulmonary vein, and this is inferior pulmonary vein. So they will go opposite right superior segmental bronchus and middle lobe bronchus. So middle lobe bronchus and superior segmental bronchus to the right lower lobe take off opposite. They take off opposite. So take off opposite. Opposite to each other from the bronchus opposite to each other from bronchus intermedius, and the pulmonary ligament is a sheet of tissue that attaches the right lower lobe to the intermediate tissue parallel to the esophagus and vagus nerve. It extends to the inferior pulmonary vein. So this is posterior and this is anterior view. And if we see laterally, this is the lateral view which we usually see during the lung during intra-op, and the middle lobe artery and superior segmental artery to the lower lobe take off opposite each other. So middle lobe artery, where is middle lobe artery? So this is middle lobe artery and superior segmental artery of the lower lobe. So this is middle lobe artery and superior segment, right lower lobe superior segmental artery, they are opposite to each other. So this is oblique view of the right lung from the surgeon's perspective through a posterolateral thoracotomy. So this is right upper lobe, the middle lobe and the lower lobe. And this is superior segmental pulmonary artery, and this is right lower lobe common basal pulmonary. This is common basal pulmonary artery. This is superior segmental pulmonary artery of the right lower lobe, and this is middle lobe. They are opposite to each other. So superior segment pulmonary artery of right lower lobe and the middle lobe pulmonary artery of they are opposite to each other, so that we can identify them. And this is phrenic nerve, and this is superior vena cava, and this is right upper lobe bronchus. This is a zygous vein, and this is superior segment pulmonary artery. So opposite to superior segment pulmonary artery, we will see middle lobe pulmonary artery. They are opposite to each other. Okay, so superior segment of the right lower lobe artery and bronchus, they are opposite to each other. And this is common basal pulmonary artery of the right lower lobe. So central vasculature with the lung removed shows the relationship of the segmental vessels. Often the superior segment pulmonary artery takes off from the interlobal pulmonary artery proximal to the takeoff of the middle lobe pulmonary artery. So the central vasculature of the lung, if we see, often the superior segmental pulmonary artery of the right lower lobe, it takes off from the interlobal, this is interlobar pulmonary artery. So from this superior segmental pulmonary artery takes off proximal to the takeoff of the middle lobe pulmonary artery. So exposure, right lower lobectomy is performed through a standard posterolateral or posterior muscle sparing thoracotomy. The chest cavity is entered through fifth intercostal space. Selective ventilation is initiated for controlled atelectasis to facilitate examination of the intrathoracic contents, and Initial pulmonary dissection, careful examination of the entire hemithorax, pleural surfaces and mediastinum are performed to rule out unsuspected metastatic disease and to assess resectability. If pleural fluid exists, it is sent for immediate cytological interpretation. Pulmonary artery dissection. Now we have seen the takeoff. Now how to dissect this pulmonary artery. So usually the arterial supply to the lobe is addressed first. Usually arterial supply to the lobe is addressed first, but as previously noted, sequence of ligation and division of the blood supply to the lung is not a critical issue. Arterial supply to the superior segment of the right lower lobe has several variations. Almost 70% of the patients have a single pulmonary artery branch supplying the superior segment. 70% have a single branch supplying the superior segment, and 99% have found to have a common trunk to the superior segment with the branch of the to the upper lobe. 11% have two branches supplying the superior segment. The remainder of the variation are illustrated. In the upper and middle lobes are retracted antero-superiorly to expose the confluence of the major and minor fissure, whereas the ILPA, inferior lobe pulmonary artery, resides. The inferior lobe pulmonary artery is exposed within the central planes of each fissure and referred to the pulmonary artery section of the right upper lobe chapter for the discussion on interlobal pulmonary artery exposure through central approach. The superior segmental artery is isolated, triply ligated and divided. So first we will isolate superior segment pulmonary artery, isolated, triply ligated and divided, or we can use the echelon. And middle lobe arterial branches will take off from the anterolateral aspect of the inferior lobal pulmonary artery distal to the superior segmental. So as we saw previously, middle lobe arterial, it will take off distal to the superior segmental artery, and often there are two branches. Distal to the middle lobe arteries, the common basal artery is isolated and divided, taking care not to compromise arcing the middle lobe vasculature. So these are the variation. In 70% there is common basal pulmonary artery and the superior segment pulmonary artery. 11% it will take off from the common trunk, and 9% have a common trunk, and 11% arising from the common basal pulmonary artery separately. So anatomical variation of the superior segmental artery to the right lower lobe, most common arrangement is single vessel. So 69% there is a single artery. 69% there is single artery to the superior segment. And surgical aspect of the pulmonary arterial supply to the middle and lower lobe lung. So if we talk about the superior aspect oblique fissure, the upper lobe is retracted superiorly, the middle lobe anteriorly. Upper lobe is retracted superiorly, middle lobe anteriorly, and the lower lobe inferiorly to expose the central hilum. At the confluence of the major and minor fissure, interlobal pulmonary artery traverses this region. So this is minor fissure, this is right upper lobe, this is middle lobe and lower lobe. So this is common basal pulmonary artery, and this is superior segmental pulmonary artery. Opposite to superior segment pulmonary artery is the middle lobe pulmonary artery, and this is common basal branch of the pulmonary artery. This is right upper lobe bronchus, This is posterior ascending pulmonary artery, interlobal pulmonary artery. So from interlobal pulmonary artery, there is this superior segment pulmonary artery. After takeoff of the superior segment pulmonary, there is middle lobe pulmonary artery, and then there is this common basilar pulmonary artery. So this is common basal pulmonary artery. This is posterior ascending pulmonary artery. Then there is this interlobal pulmonary artery. Then there is this superior segment pulmonary artery and common basal pulmonary artery. And this is middle lobe pulmonary artery. The confluence of the fissure is entered and a plane of dissection is created within the fissure. So confluence of the fissure is entered, the plane of dissection created within the fissure to expose the periarterial, fibrofatty and lymphatic tissue. The periarterial plane of larynx is entered to expose the interlobal pulmonary artery, and overlying parenchyma is incised proximally and distally to better define and expose vessel. Posterior ascending, middle lobe, superior segmental and basal arteries are exposed. So this is superior segment pulmonary artery, that is middle lobe pulmonary artery, common basal pulmonary artery. So superior segment artery is isolated, ligated proximally. If more exposure of the vessel is needed, periarterial tissue are swept distally for short distance and the vessel is triply ligated and divided. Common basal pulmonary artery, middle lobe pulmonary artery. So here the superior segment pulmonary artery is ligated and divided, the middle lobe pulmonary artery, and this is common basal pulmonary artery. So the common basal pulmonary artery is triply ligated, divided, and care is taken not to place the proximal ligature in a location that kinks or compromise the middle lobe artery. So we have to take care of the middle lobe artery. So this was about artery. Now the base of the right lower lobe is grasped and retracted superior. So right lower lobe we will grasp and retracted it to superiorly and anteriorly to expose the pulmonary ligament, and the pulmonary ligament is then divided to the level of inferior pulmonary vein, and the pulmonary ligament lymph node station 9, level 9 is excised for analysis. So this is the inferior pulmonary vein, and this is the pulmonary ligament which is incised up to the level of the inferior pulmonary vein. Inferior pulmonary ligament is incised up to the level of inferior pulmonary vein. Station 9 node are here. So pulmonary vein dissection, the base of the right lower lobe is grasped, retracted anterior-superiorly to expose the pulmonary ligament. The pulmonary ligament to the level of inferior pulmonary vein, maintaining a line of dissection lateral to the vagus nerve. The pulmonary ligament lymph node level 9 removed for permanent analysis is usually the inferior pulmonary vein is not juxtaposed to critical structure and is readily isolated. On occasion, however, the neoplastic process extends to the inferior pulmonary vein and invades adjacent pericardium. In such circumstances, it is extremely important to be cognizant of the possibility of intravascular extension into the left atrium. Pulmonary manipulation is minimized. The pericardium is incised. A ring of pericardium is included with the inferior pulmonary vein resection. So intrapericardial resection of the inferior pulmonary vein, and once the pericardial cavity is entered, the left atrium is gently palpated for tumor thrombus, and if necessary, a small portion of the left atrium is included with the en bloc resection. Otherwise, inferior pulmonary vein is divided after ligation with the vascular stapler or with ties and suture. So this is the inferior pulmonary so this is the inferior pulmonary vein is slightly separated from the other hilar structures which facilitate its dissection, and this is the inferior pulmonary ligament which is incised and it is isolated and encircled. The inferior pulmonary vein divided between the ties and sutures or vascular staple line. Lung is reflected anteriorly. So lung refracted. So now this first we retracted lung superiorly, anteriorly and superiorly to expose the inferior pulmonary ligament, and inferior pulmonary ligament is incised up to the level of inferior pulmonary vein, and then inferior pulmonary vein is looped and ligated and divided. Now again we will expose the lung. The lung is reflected anteriorly to expose the posterior hilum. Now posteriorly we will see azygous vein, and the mediastinum pleura is incised to initiate exposure of the posterior aspect of the bronchus, and the bronchial tissue are swept distally and inferiorly until the bifurcation between the right upper lobe bronchus and the bronchus intermedius they are identified, and the lymph node tissue in this area, that is interlobar station 11R or some lymph node 11R sump lymph node is excised for pathological examination. The bronchial artery usually traverses the posterior surface of the right upper lobe bronchus. So right upper lobe bronchus, posterior to right upper lobe bronchus is the bronchial artery, supplies this sump lymph node station 11R, and the node is an important landmark, usually overlies the bronchial bifurcation and the pulmonary artery, typically between the superior segmental and posterior ascending arterial branches. So here we can see a hand is placed along the posterior aspect of the major fissure, and the thumb is placed in the bifurcation between the right upper lobe bronchus and the bronchus intermedius. Right upper lobe bronchus, so this is right upper lobe bronchus and bronchus intermedius, and thumb is placed here in between, and the index finger along the anterior aspect of the fissure with the fingertip at the level of the confluence of the fissure or the central interlobar dissection. So right upper lobe, right main, this is right main bronchus, this is right upper lobe bronchus, right main bronchus, and this is right upper lobe bronchus, and now this is right main bronchus, and now we can see it is going into right upper lobe bronchus, this is bronchus intermedius, divided into superior segment of the superior segment, and this is the right lower lobe bronchus, common basal bronchus. The posterior aspect of the major fissure is grasped. The thumb is placed in bifurcation between the right upper lobe bronchus and bronchus intermedius, and the fingertip passed into the previously dissected central aspect of the fissure to the ligated right lower lobe segmental vessels, and some of the tissues between the thumb and forefingers are thinned with small amount of finger dissection, and keeping in mind the precise location of the pulmonary artery within the confluence of the fissures. A large right angle clamp is passed from the central interlobar dissection to the bifurcation of the right upper lobe and intermediate bronchus to encircle the posterior major fissure, The clamp is spread wide enough to allow for the insertion of a linear stapler, which is subsequently passed through this plane and fired. Alternatively, parenchymal tissues are divided between parallel clamps and oversewn with a running suture. The posterior aspect of the major fissure is divided either before or after division of the posterior ascending artery. The sequence depends on the ease and safety of the exposure. After division of the arterial supply to the lower lobe, the underlying lobar bronchi are identified, and this bronchi are used as a landmark to complete the major fissure inferiorly. And to better visualize the posterior aspect of the middle lobe and right lower lobe bronchi, the pulmonary parenchyma is swept distally. The bifurcation between the middle lobe and lower lobe identified and is well exposed using blunt dissection, and a large right angle clamp is passed into this region inferior to the middle lobe bronchus and underneath the pulmonary parenchyma in a lateral to inferomedial fashion. The clamp tip exists inferior to the superior pulmonary vein. The clamp travels along the anticipated course of the fissure inferiorly and serves as a guide for division of the fissure. The inferior aspect of the fissure is completed with the electrocautery, a linear staple or suture. So this is posterior ascending pulmonary artery. This is middle lobe pulmonary artery, and this is common basal pulmonary artery and its branches, and this is the superior segment pulmonary artery stump. Now superior aspect, this is the right upper lobe, right upper lobe bronchus, right upper lobe bronchus. This is right upper lobe bronchus going here. Then this is bronchus intermedius, and this is right lower lobe bronchus, and this is a main bronchus. Right angle clamp is passed under the parenchyma of the posterior fissure, major fissure, and the clamp is passed anterolateral to the interlobal pulmonary artery within the region of the central interlobar dissection and superior segment arterial stump. With the clamp in place, the lung is rotated anteriorly to expose clamp tip that emerges at the bifurcation between the right upper lobe bronchus and the bronchus intermedius. So this is right upper lobe bronchus. This is azygous vein, right upper lobe bronchus and bronchus intermedius, and this is main bronchus. So stapler is applied across the posterior aspect of the major fissure along line delineated by the right angle clamp. And the central fissure are exposed. Right lower lobe and middle lobe bronchi reside slightly inferior and medial to the common basal pulmonary artery stump. So this was the common basal pulmonary artery stump, which is ligated, and the right lower lobe and right middle lobe bronchi, they reside slightly inferior and medial to the common basal pulmonary artery stump. So fibrofatty tissue overlying the bronchi is swept distally to expose the region between the right middle lobe and common basal bronchus. So a right angle clamp is passed through the bifurcation between the middle lobe and the common basal bronchus to encircle the inferior aspect of the major fissure. The clamp tip exists inferior to the superior pulmonary vein. A linear stapler is used to complete the fissure. So for bronchus dissection, before division of the right lower lobe bronchus, it is extremely important to clearly identify the proximal middle lobe bronchus to avoid compression or kinking of the middle lobe bronchus. When stapling the right lower lobe bronchus, at the proximal takeoff of the right lower lobe bronchus, the overlying parenchyma is swept distally to expose the superior segment bronchus and the common basal bronchus. A linear stapler is applied across the bronchus. Before firing the stapler, lung is inflated to ensure adequate and easy expansion of the middle lobe. And if a stapler is applied across both the common basal bronchus and the superior segmental bronchus, the staple line will approximately reside well apart from the middle lobe bronchus. Misapplication of the stapler results in permanent stenosis of the middle lobe bronchus, and if there is any question of possible compromise of the middle lobe bronchial lumen, superior segmental bronchus and the common basal bronchus are closed individually. The key principle is avoidance of the narrowing of the middle lobe bronchus. So this is a linear stapler which is applied across the base of the right lower lobe bronchus. This is middle lobe bronchus and this is bronchus intermedius. So right middle lobe bronchus, superior segment of the superior segmental bronchus. So we have to staple fire is done. So staple firing is done. Here at this level. So this is the middle lobe bronchus, this is superior segmental bronchus, and these are the common basal bronchus. So we have to fire a stapler at this level and avoid narrowing of the right middle lobe bronchus, or we can double fire this and this separately. So say a staple line is placed across the base of the common basal bronchus and the superior segment bronchus to ensure patency of the right middle lobe bronchus without compromise of the middle lobe bronchial lumen. And if the staple line is applied too close to the origin of the right middle lobe bronchus, the lumen is irreparably narrowed. And to avoid possibility of this compromise, superior segmental and the basal bronchus are sometimes individually closed with a linear stapler. And because the right lower lobe bronchus is dependent bronchus subject to slight more pressure, pulling of secretions, coverage of the bronchial stump with pedicle parietal pleural flap is performed to enhance the integrity of the closure. Kinking torsion of the middle lobe has been reported following upper lobe and lower lobectomy, and this most often occurs when a complete fissure is present. And to prevent such occurrence, the upper and middle lobes are inflated and their